All right. Hi, everyone. Welcome to the next edition of the Laser Skin Surgery Center webinar series. Today, we are very excited to be here with Dr. Roy Seidenberg, and he is going to be speaking on acne and rosacea. So I'll let all of you get situated here, and while you do, on the bottom of your screen, there's a few options. There's a chat feature if you want to communicate with me privately. And there's also a Q&A feature, which is the ideal place to put any questions for Dr. Seidenberg. If you already know what you want to ask, you can start populating them now. As he's going through his presentation, if a question comes up, you can use it. And at the end, when we finish the presentation and we open up for Q&A, you can add more as we go. So Dr. Seidenberg has a really educational presentation prepared for you, all about acne and rosacea. And then at the end, we'll have time for question and answer. Before we get going into this, I think a couple of you are still joining, but I want to run a little poll so we can get a sense for who is here and what you guys are looking for. So there should have been a little poll that just popped up on your screen right now. The first question is, what acne or rosacea treatment have you tried? Have you tried over-the-counter topical medications or maybe some at-home holistic treatments? Have you tried a prescription topical medication, prescription oral medication, Accutane, or laser or other treatments? What is your age? Pretty self-explanatory. What do you think worsens your acne or rosacea? And what are you struggling with today? So,
and Rita, on the first question, can they click more than one or just one?
Yes, you can click multiple options for all of them except for your age. You have to just put one age. If you are streaming on Facebook or on your phone, you might not be able to see this, so you're welcome to tell me in the chat what your answers are. But otherwise, this is just to give Dr. Seidenberg a little sense of who's here today. So only a couple of you have, okay, I'll let 5 more seconds. You guys get in the rest of your votes. Up. Still more coming. Okay, I'll give it another minute. 4 questions. All right. Please press submit. All right, I'm going to end this poll and I will share the results so you all can see. Dr. Seidenberg, can you see those?
I can, thank you.
Perfect.
All right, well, a lot of you guys with laser, good, okay. All right.
So for not everyone that can see the answers here, it seems the majority of you have tried prescription topical medication. And, oh, whoops, hold on. Most of you are 40 plus. Most of you think your acne and rosacea worsens because of stress. I totally agree. And most of you are here today are actually interested in learning about rosacea. So with that in mind, let's get started. So Dr. Seidenberg is a board-certified dermatologist that we are very lucky to have at Laser Skin Surgery Center. He has almost 25 years of experience. He's been in practice since 1998. He was actually first board-certified as an internal medicine doctor before he became a board-certified dermatologist, which gives him a little bit of unique experience. He's an assistant clinical professor at NYU, teaching residents every week. Also, and a consulting physician at the NYU VA hospital. He has a unique focus for Laser Skin Surgery Center because he focuses primarily on medical derm. So this lecture webinar today on acne and rosacea is right up his alley. But of course, he does do some cosmetics. He also does other areas of medical dermatology, such as genital warts and STDs, rashes, lumps, bumps, and mumps. Of course, skin cancer screenings, which is our bread and butter. But also, not many of you might know, but dermatologists are also experts in hair and nails. Another couple fun facts about Dr. Seidenberg. He was born in Long Island and of course now lives in Manhattan. And I wanted to just make sure that you guys know that any patient of Dr. Seidenberg sees him individually and only him, as well as everyone at our center. All of our treatments are performed by MDs, so no nurses or PAs. And the best fun fact is that most everything that he's going to talk about today is covered by insurance, and we and Dr. Seidenberg accept most medical insurance and Medicare. So we accept all the major ones such as United, Aetna, Oxford, Cigna, Empire, and if you have any specific questions, we'd be happy to answer. There are thousands of specific insurance within each one. And let's see, our last thing just to let you guys know is we don't sell any medications at our practice. So if you do come see Dr. Seidenberg, he will most likely be writing you a prescription. And lastly, I know there's lots of different people here today. Some of you might be only a little bit educated about these topics. Some of you may be very educated. So Dr. Seidenberg is going to do his best to try and speak to all of you. So I hope it's a good level for everyone, and feel free to use that chat feature if you have any questions. So with all that said, I am very honored to introduce Dr. Seidenberg.
Thanks so much, Risa, for organizing this, and everybody for coming. I know you gave up all your concert tickets to Broadway plays and the movies tonight and all those fun places and the restaurants. So thanks for coming just to watch me. Okay, so actually I'm glad we did that poll because it was more of a rosacea crowd than I would have guessed. But I'd just like to say, as I have no financial conflicts of anything that we're bringing up because I don't sell any medications. And the patients that you're seeing are not mine. They are the practice. So we will start with acne, and we're going to go over some general information, the different types. We're going to, most importantly, we're going to go over why it happens, how it evolves. Because I do think, while some of you might have been over 40, I think there's, from what I've heard, a fair amount of you that are actually here for your teenagers and kids, such as mine, who are on their medications at home. And because if we know the pathophysiology, then of course we know, why we pick the medications that we do and why we do the treatments that we do. And afterwards, we'll then talk about rosacea. And some of the treatments are overlapping. So acne, of course, is extremely common. It's the most common skin disorder we see. I've seen a lot of acne over 25 years. Really, at some point in their life, 85% of Americans will have acne. That's about 50 million people now. And really, almost 20 million people will have significant acne and with causing scarring, which of course we see a lot at the laser center here. And there's about $3 billion worth of medication spent every year. So it's a big concern. And as you see on the graph, where of course as teenagers, it's the most common, and men are more common, but as we get into adulthood, which we really do see a lot of adult acne, I think more than we used to for reasons that we may not fully know, then it actually gets more prominent in women. So we see a lot of adult acne in women in their 20s and 30s, even if they've never had acne as a teenager. And of course, acne is so important because it has such an effect on one's psyche, one's self-esteem, and some kids don't even want to go to school, and that's before COVID. So, okay. Of course, the question is the acne making the depression and anxiety worse, or is it the other way around? It's probably a little bit of both. So what causes the acne? Genetics plays a large role, but it is, of course, so common. Hormones play a major role, especially as a teenager, or a hormone problem in women. Stress, and I'm actually a big believer in stress. And I will say, since a lot of you mentioned stress as well, that if you feel stressed, it can cause a physical problem. But I also believe one step further that you can feel great, but if your Freudian unconscious mind is not happy, that can initiate physical disease like acne or rosacea as well. There certainly could be a mechanical component. A lot of my patients tell me about that. Their makeup, they worry about their makeup. They're getting some maskne these days. They wonder if exercise. A lot of people get worse with exercise, even though there's not a great reason for that physiologically. And diet. And diet is interesting because just over the decades, diets have changed every 10 years. There's always a different concept about diet. Our thoughts of diet and acne have changed over the decades as well. Milk and chocolate were big then, it faded out. But right now, the two common biggest trends we have are actually milk. So it's back in vogue. Interestingly, a lot of the studies only showed skim milk, which was a little bit counterintuitive. Some people, it's all milk. And in a lot of these studies in different countries around the world, it really doesn't take a whole lot of milk. Personally, I drink almond or soy. I think it's better for me. I think it's better for the animal. It's better for the planet. So if you have acne, it's probably just a good choice regardless. And what's also interesting, although it's milk, I didn't say it's dairy, because in a lot of these studies, while milk was a problem, it wasn't really yogurt or cheese. And just this month, a French study with 25,000 people taking surveys confirmed that as well. It's not the first time we've seen that. And maybe that, again, feeds into the French paradox, how the French get to, they smoke, they eat well, they drink a lot, and they're thin and they're healthy. So how they do it, we don't quite know. But the other big trend, which is very coming and getting more and more popular, and we're seeing this for many skin problems and health problems, is the high glycemic diet. And of course, this is a concept that, we didn't really think about in 20 years, what that meant. This of course is your French fries and all your flour and your rice and all the white foods. But even a piece of organic whole wheat bread has a relatively high glycemic index. And this will then increase your insulin-like growth factors, other pro-inflammatory mediators, and make acne and inflammation worsen. And again, we've seen this in several studies around the world. So this is the latest trend. So Mediterranean diet might be better. But you know what? This slide will probably be very different when we talk about diet in another 20 years from now. Okay, so let's just talk about some misconceptions and realities. So first of all, acne is not an infection. These are the realities I have listed here. It's an inflammation. There is a bacteria in the skin, and that's Cutibacterium acnes. Used to have a different name, but it hired Lisa for marketing and changed its name to something cute. So now it's Cutibacterium. Acne is not caused by dirt, so you don't have to wash your face 100 times a day. Personally, I think exfoliating is overrated and might make it a little bit more to be dry. And while it's very tempting, spot treating doesn't work because the pimple is already there. That's what cortisone shots are for. So you really need to apply your medication to the whole area involved. And you got to be patient because acne medicines don't work quickly. They don't work in days. The skin's got to turn over, so to speak. We're trying to prevent it. So some things are 3 weeks, some things are 6 weeks. Even birth control pills can take even 3 months. So especially for a teenager, unfortunately it's not an instant gratification. So let's just review the skin a little bit so you can understand about the treatments that we're doing. So here's the top of our skin here, and we have a pilosebaceous unit, our hair follicle with an oil gland. Here it is on the left in cross section. And you can see the epidermis continues right along and goes right down into the hair follicle. So it's all continuous right down to the hair shaft. And what I find fascinating, despite how small this is that every single hair follicle has its own little tiny nerves, its own little muscle, its own oil gland, of course. And it's got its own little artery and blood vessel going right by it. There's a little tiny artery and blood vessel all over in your dermis over here. And the hair follicle goes pretty deep, as you know, if you ever plucked a hair. And this is where it all takes place. So when we think of acne as the pathogenesis and why it starts, it's about 4 or 5 issues. And we can kind of break it down into our non-inflammatory acne, basically your whiteheads and blackheads, or your comedones, your open and closed comedones, and are progressing to the right where we get our inflammatory acne, our bigger lesions. So as we say, the first part where just like we shed our skin in a normal way, that's the keratin, like our hair and our nails. We shed the skin, it goes up nice and normal, it goes into the air, that's what we call dust. But in the follicle, if we don't shed it properly, we get a little plug that we can't even see. And that's a microcomedone. So a micro blackhead or whitehead, can't quite see it yet, but it plugs the follicle. And so we get a little plug over here. And now what happens is that we have our oil gland, which makes sebum, and the sebum comes out and that gets a little backed up. And these little blue dots here are little bacteria, these little blue things over here living in our hair follicle. And as it goes on here, our sebum collects, their keratin is collecting, the bacteria starting to multiply. And so we have our little whitehead. If it's deeper down, it's a whitehead. If it's a little higher up and open to the pore, visible, it's a blackhead. And it's not black because of dirt, it's black because the melanin does oxidize, just like a banana turning dark. We wish it stopped there, but things sometimes will then escalate into the inflammatory acne here. And what happens is that your bacteria sees the sebum and oil, and it's like a nice big all-you-can-eat buffet. So the cholesterol, the triglycerides are food for the bacteria. So the bacteria eat your triglycerides, and that creates these free fatty acids. And these free fatty acids secrete chemicals, and the chemicals attract these little white blood cells that you have here to actually leave the little blood vessel going by your hair follicle, and it sees these free fatty acids, and it sees these bacteria that are now multiplying, because it's eating and multiplying, as abnormal, like there was an infection or even a splinter. And so white blood cells are now going into these little red things here, these neutrophils as we call them, and they're attracted. We call that neutrophilic chemotaxis. And what do you call a lot of white blood cells? Pus. And so now we have pus, we have a little bit of oil, and we have the bacteria. And so we have their inflammatory acne, our pimples, and our pus bumps, our papules, and our pustules, and our bacteria is multiplying. But it's still moderate acne here, still in our hair follicle. But now, of course, we have our hormones coming in, stimulating our oil glands, and increasing the oil glands to enlarge. And now we get more inflammation, which it can get so big, it gets deeper. What most patients call a cyst, but medically we call it a nodule. Nodular cystic acne, deeper acne. And if it breaks, it can break through the follicle, the pilosebaceous unit on its own, or worse, you squeeze it. And that's bad because now the inflammation breaks through into the surrounding skin. That creates more inflammation to come in. You have more pus. And the problem with that is that these white blood cells are releasing enzymes, and those enzymes are to kill the bacteria, but they also kill or damage your skin, and that's going to cause scarring. So acne, inflammatory acne will cause scarring. Yes, picking will create more, but acne is a scarring process if it's bad enough. And if we understand this, then we know which way the treatment goes. And on top of that, we have our diet, high glycemic foods, increased insulin-like growth factors, stimulates androgens, the hormones, converts hormone production, maybe the hormones in the milk, we don't know. Your own hormones come in. We have androgen receptors on our oil glands, and then we get thickening of the skin and thickening of the oil gland, and it's a mess. So here we have some mild acne. It's comedonal, and there are little whiteheads and blackheads over here. And this is a good patient for the talk, because this is a guy who, a little red background, a little red on the nose, and he probably has a little rosacea as well. So he's got a little overlap, and you can certainly have both. We have a more involved, we have our milder, moderate inflammatory acne of pimples and pus bumps. And you know that this is going on for a while because we could see all the acne scars. So this has been going on for a while, or it was worse in the past. And then we get to the more severe acne. Look how big this nodule is, connecting under the skin. We call this a sinus, and all the pus. And again, we can culture this. It's always a good idea to culture it, make sure they didn't have an infection, but this will be sterile. It's all inflammation. Of course, we have some rare severe types we might call fulminans or conglobata, but this is about the worst it gets. Darker skin types as well. You can see the whiteheads and blackheads and whiteheads, the papules and pustules, and again, the cysts or nodules and the resultant scarring. Of course, acne is not just the face, a lot of back, trunk, and shoulders as well. So again, depending on what type of acne, it's how severe it is, what type of morphology it's presenting with is going to dictate what the types of medicines we use, and of course how aggressive as we get on into our oral therapies and our more intense oral therapies as we go down our algorithm of treatments. But even the maintenance therapy, which we'll start with, are good old retinoids and benzoyl peroxide. And so again, when we're looking at our pathophysiology and our topical medications, we have different medications in different classes because they really are going to focus on different things. So the retinoids are for the keratin growth. Benzoyl peroxide will lower the bacteria in the skin, and most of these medicines do have some overlapping features. Our new androgen receptor topical blocker to block the hormone. And then we have our topicals to cut down the white blood cell coming into the skin. And if you have a real big zit, you come into the office and we give you a shot of cortisone. Okay, so retinoids are really our mainstay, a great acne medicine, very effective, and really the best thing for your comedonal acne, but also for your inflammatory acne. And of course has the added benefit of being anti-aging. It helps find scars, it helps find lines. If you have rosacea, it's not really a main rosacea treatment, but in the long run could lessen the redness from rosacea as well. And so many 40 to 50-year-old women are using this every single night forever. The main downsides, though, the reasons why people don't want to use it or stop using it is the dryness. So this really is one of the more drying acne medications. And it can make you a little sensitive to the sun or waxing. You gotta stop it a few days before. So we have a lot of retinoids. Three main classes for the most part are tretinoin, aradapiline, and we can add some clindamycin, and we can add some benzoyl peroxide. Our tirazetine, maybe a little stronger, but maybe a little bit more drying. It comes as a foam, and that's nice for the trunk. Covering a large area is easy with a foam. And what's new and exciting, calm down, is a brand new retinoid, Acleaf. So really up to about 2 years ago, there wasn't that much going on in what was new in acne for about 15 years. The way we practiced was different, but there weren't that many new products. So Acleaf, but we got some new things in the last year or two, Acleaf. And what makes retinoids different from one another are there 3 receptors, and the Acleaf is more of a gamma receptor, supposedly better for acne. Also the first retinoid to actually get FDA approval for the trunk. And that's brand new. I haven't even seen that many patients back yet. Benzoyl peroxide, again, been around there forever, and but very effective, and it's cheap. It could be over the counter or prescription or a combination. You can rub in a thin layer, or you could use it as a wash. And the nice thing is you never get immune to it. So it's not an antibiotic in the traditional sense. It uses free oxygen radicals to kill the bacteria, and you never get immune to it. And that's why sometimes they will combine other antibiotics with benzoyl peroxide. Can be a little drying though, and it really depends on percentage. You can get as low as about 3% or so. And if you're putting on a cream, 3% is totally fine. It actually works the same as 10%. 10% is only if you're really oily. Otherwise, it's marketing. 10% doesn't work any better than 3% if you're rubbing it in. If you're using a wash, however, then you want to go to 8 to 10% because it's really not on your skin that long. And it can bleach. The other side effect to be aware of course, is fabric. So you put it on in the morning, careful for your towel or your turtleneck. Put it on at night, you gotta worry about your bed sheets. It can even bleach a countertop. When I was a teenager, like 4 micro countertops. And every once in a while, we'll actually see allergic reactions. Not too common, but something to know about. So about 10 years ago or so, we had a new topical, which was Dapsone, which is a pill. Too many side effects to use for acne as a pill, but made into a cream, and quite effective. Actually works for some reason better, a little bit more better for women than men. Not drying at all, very well tolerated. I often will put it under the retinoid at night, and works pretty well. And so that's a nice addition, different class. Azelaic acid's been around for a bit, and this is something that we use for, hence the name Echinacea. We use it for rosacea, first used for rosacea, but then they realized it worked for comedonal acne, works for rosacea, also used or recommended for darker skin types with the retinoids, and because it does have some bleaching effects. So the retinoids and the azelaic acid will bleach the brown spots. So darker skin types, blackheads, rosacea, a good choice there, but not really the strongest of the acne medications. It does work well for rosacea. and a little bit of irritation. And a lot of patients coming in, going to see an internet dermatologist coming in with some very expensive azelaic acid, but really not one of your stronger acne medicines. So another new and exciting, I know, stay calm, minocycline, which I took as a 15-year-old by mouth. It took about 40 years, finally available. The first time a tetracycline has been made into a topical, and it is a foam. And again, that's nice, especially if it's on the trunk or back, a large area, makes it easy to cover, pretty well tolerated, and that's a nice addition, and can be used for the rosacea as well. And coming soon, another topical, the generic product cyclosterone, and this is an androgen receptor blocker. We don't know the name yet, and hopefully it won't start with an A like all the other new products. And this just came out, and in your oil gland, you have, and where you have your hormones, and more hormones are made even right in your oil gland. It binds to your androgen receptor, and then that goes into the nucleus and creates synthesis, and replication of all your skin and your oil glands. And the blue bump here, the blue little circle, blocks that receptor and stops that pathway from getting worse. So we do have some new things. If you haven't been in the office in 2 years, we got some new classes of acne medicine for you. Of course, we have some other medicines that really not quite as effective. So the top 3 are prescription, the bottom are over the counter. Clindamycin, so erythro, I haven't written a topical erythromycin prescription if it was my choice in 20 years. Virtually everybody is immune to it by now. Clindamycin, a lot of people are allergic to clindamycin, especially if you're using this alone. So these are not for long-term use. If you had a bacterial infection, use it for 2 weeks, that's one story. But if you've been using clindamycin for 6 months or a year, you're probably immune to it by now. And that's why they've made these products in combination with benzoyl peroxide, because then you wouldn't become allergic to them. Sulfa, a mild effect for acne, more for rosacea, and some over-the-counters with mild effects, even tea tree oil, admittedly, with a little bit of effect as well. So again, we go back to our diagram. If we want to stop the comedones, we use a retinoid. Benzoyl peroxide reliably will lower the bacteria. The anti-androgen will block the receptor. Minocycline and dapsone will help minimize the white blood cells from coming into the skin. Okay. And I do want to make a note that sometimes about cost. So we don't sell medications when you have good prescription medications, but they can be expensive. But there are ways around this. I never want you to spend a lot of money for your medications. So we have coupons. And also what's very important is that there are pharmacies that are really a lot better than other pharmacies when it comes to using these coupons and processing the coupons. Your typical very large chains won't do this for you. And so heed my warning when if you come on in, use a special pharmacy, it can save you a lot of money, time, and headache. And also less pre-authorizations are required and it's more likely to get approved. And that goes for pills too. So when it comes to your inflammatory acne, we have 4 major classes of medications, the antibiotics in the tetracycline family. And I will say there are other antibiotics, but I really don't use other antibiotics like azithromycin or Bactrim for long-term use. They're too important and you don't want to get immune to those. Also, the tetracyclines are probably more directly anti-inflammatory. So tetracycline class is tetracycline, which I really don't use that much of, doxycycline, which is the main workhorse, and minocycline, popular, but I think getting a little less popular over time. And then, of course, birth control pills, you're probably more familiar than I, and their pros and cons. Spironolactone is our androgen blocker, and that's really made a big comeback, really exploded in the last, say, 20 years. And of course, 4th bedding cleanup, last but not least, is our Accutane. We call it Accutane, it's isotretinoin. Accutane was the first brand. It's actually made by Roche, and that's actually, they're not making it anymore. So isotretinoin, but I'll call it Accutane for the most part. So the tetracycline class, very common, an antibiotic. And again, as an antibiotic, it's going to lower the bacteria in the skin, and it's going to help stop the white blood cells from coming in, so reducing inflammation. Our main side effects are upset stomach and sensitivity to the sun. You can't use it, or any acne pill for that matter, if you're pregnant. And of course, with an antibiotic, a chance of a vaginal yeast infection. And those are the main, a couple other side effects, those really are the main ones. Some you can't take with food, or they get binded by calcium, iron, or aluminum, so you have to be careful what you take it with. They do not decrease birth control efficacy, which was a concern 20 years ago, and really not too many drug interactions, but you ironically can't take it with Accutane. Comparing one class to the other, minocycline used to be really the number one, and maybe it still is. The side effect wise, what's nice about it is less likely to upset your stomach than doxycycline, less likely to be photosensitizing. But there's still a little bit, and then we have the added side effect in the beginning of a little dizziness or headache, because it does cross the blood-brain barrier. But it's becoming a little bit less favored because of these rare, more serious side effects. Oh, my first typo. And if you use it for a long time, you can actually get blue discoloration. So before Accutane and the other medicines, people would come in literally addicted to it. Their ears would be blue, their whites of their eyes would be blue, and they'd be begging you for their minocycline. Once in a blue moon, it can set off a lupus-like reaction, rarely inflame the liver. But more and more, we're seeing these systemic allergic reactions, which could be even persistent after you stop the medication. So it's falling a little bit less popular. It's still used, though. Don't be afraid if you're on it, just something to know about. Doxycycline is really the workhorse for reasons you'll find out in a second. But again, it does make it sensitive to the sun. Got to be careful about the stomach. Take it with a good glass of water. Some forms you could take with food or not. And it will also cover some things like MRSA, if you, let's say, have a bacterial infection going on that we don't realize, cover your Lyme disease, your chlamydia, or your Rocky Mountain spotted fever if you have any of those. But what I really will say that I really try, and of course over the years, all of us try to not put people on long-term antibiotics. And the heyday of the Accutane concerns were really about 10 years ago, so it was very common. So how do we get people off of long-term antibiotics? We use the other pills. And then about 10 years ago or so, they came out with a low-dose doxycycline. And the brand was called Oracea, which, as you guessed, rhymes with rosacea. So it came out for rosacea first. Again, there's a similar inflammation there. And it actually, interestingly, works better for rosacea than it does for acne. So rosacea is more sensitive to the tetracycline pills. And this is, so if you take doxycycline, which you might take at 200 milligrams a day, but take it as even 50 milligrams once a day, above this blue line over here, if you can see that, it now becomes an antibiotic. However, at 40 milligrams a day, it stays under that line and is no longer an antibiotic. So you're not taking a long-term antibiotic. You don't get any antibiotic side effects, and you're much less likely to get upset stomach or sensitivity to the sun because it's a lower dose. And we do have a couple studies showing that the lower dose for acne will work as well as the higher dosages. So that's a preferred point. I really try to avoid long-term antibiotics. So that's one of my workhorses. Birth control pills, of course, can be very helpful for acne. Actually, FDA approved for acne if you're looking for birth control as well. And Yaz and Yasmin, a couple others, orthotricycline low, probably FDA grade studies, FDA approved. Small risk for Yaz because of its fourth generation progesterone, drospirenone. There's a very slight increased risk of blood clots, but still very low from baseline. And that's why we may not give it to someone who's smoking. Also, because Yaz is a 24/4 pill instead of being off hormone for 7 days, periods are shorter, less PMS symptoms as well. So of course, a lot of uses for birth control pills, very helpful. And most of these medications, by the way, can be used together. And of course, Spiro, short for spironolactone, and very safe, which was also initially a high blood pressure medication, a diuretic for congestive heart failure, high blood pressure, found to have anti-androgen effects. So if any of you are on Spiro, or you have kids on Spiro, thank this guy, Dr. Shaw. So about 2 years after I graduated, he put out this article saying, instead of, in residency, I would only use Spiro if a woman had polycystic ovary syndrome. And this article said, you know what, even if they don't have a hormone problem, it's still very effective for acne. And ever since the 2000, when this was written, my Spiro went from like 3 a year to maybe about 3 a day. And this is really a workhorse. It's got a great safety profile. So testosterone leaks out of your blood and wants to stimulate your oil gland and hit the androgen receptors to cause more problems, and the Spiro will block that. So since it blocks all things related to testosterone, it will work for polycystic ovary syndrome, hirsutism, facial hair, hormonal hair thinning, or really even just really oily skin. And it could be used with all the other medications. Side effect wise, the basic thing to know when I tell my patients, so again, you can't get pregnant on it, but breastfeeding is actually okay. One of the few things that we can use if you're breastfeeding. So your main side effects here, be aware of a little change of your menstrual cycle. And there's a small chance of headache, dizziness, or it can make you pee a little bit more. It usually does not lower your blood pressure. If you had a low blood pressure, maybe we wouldn't use it, but generally it's not a problem. You might have heard it could increase your potassium, but in young, healthy women, this is quite uncommon. We have lots of studies showing you do not need to check your blood routinely unless you are on some heart medications, blood medications, lots of anti-inflammatories, and don't drink gallons of coconut water, and avoid those unhealthy, low salt processed foods because those can raise your potassium. Breast tenderness, a very uncommon complaint. 20 years ago, there was a concern, does this increase breast cancer? We have some very good, very large studies showing that is not a problem. So that's a great workhorse. It can be used with Accutane as well. And of course, why is Accutane so effective? Well, all the things that we mentioned, and we had 4 or 5 other drugs, we pretty much have Accutane. It is a retinoid like Retin A, so it helps the skin grow normal. It lowers the bacteria in the skin. It doesn't block your androgen receptor, but it shrinks your oil gland. A couple of years ago, there was a topical that was trying to minimize your oil gland. Didn't work out. Accutane will stop your inflammation from happening here. And the little known secret, it actually helps scarring. So people who go on Accutane actually look better at the end. Their scarring is better at the end of their course and even 6 months after that. So Roche came out with Accutane, but they stopped making it. But again, here's the 4 things. A lot of people think they're gonna take it for 5 months. They'll never have a zit again. It's a great medicine, but it's not a 100% cure. There are people that do need multiple courses, especially with women with underlying hormone problems. And of course, if you've been on the internet or you've heard the stories, some people are a little hesitant for Accutane. This was a big issue maybe about 10 years ago or so. Ulcerative colitis, depression, suicide. Basically, one senator's son didn't get into the Ivy League school of his choice, committed suicide, and that's how the whole thing snowballed. And the lawyers went from there. No offense to lawyers. Again, a little more scare. But fortunately now, we have very large studies, 7,000 patients, multiple studies showing that there's never been a cause and effect. It's depression and the inflammatory bowel disease not increased, and if anything, more likely to have less depression for reasons that are quite obvious. So we feel a lot better about that. And since we want to keep people on antibiotics, the pendulum has swung again, where it was going down about 10 years ago. Now Accutane is much more accepted, and I think much more used, keep people off long-term antibiotics. So a course is about 5 to 6 months, and pay attention rosacea patients, because we can use this for severe rosacea. We do check blood work, and we need to see you for bloods every month in the office. It is actually regulated by the government for pregnancy reasons. The main side effects are basically 3 side effects. You get dry in the beginning, dry, especially the lips. It makes you sensitive to the sun, and you get a little bit of a flare. We can control that. We're making sure we monitor the blood. We're checking your liver, which is really rare. We are checking less blood than we used to. We have good studies on that. It can raise your fats in your blood, so we're checking your triglycerides, cholesterol, Rarely do we ever have to stop it for that reason, unless there's a personal history or a strong family history. And of course, you cannot get pregnant. Serious birth defects have to be on 2 forms of birth control. But, and we know this, it's been out 30 years, a month after you're done, you can get pregnant. There is no problem. I've heard so many women worried that I've heard otherwise. Again, if you do have underlying PCOS or hormone problem, unfortunately, the cure rate is lower. And I've been running into that a little bit more the last few years for reasons don't fully know why. So to make sure nobody gets pregnant, we have the I Pledge program. This is the 3rd attempt to help women not get pregnant. Not very easy for men, but for women, every single month, I have to go online, then you have to go online, answer questions, then your pharmacist has to go online. We have to time your prescription to when you got your pregnancy test. A little bit annoying, but we get it done. When you get your Accutane pills, you hopefully get the message not to get pregnant. However, despite that, still 150 women every year are getting pregnant on Accutane. Lastly, as far as treatment goes, we have our procedures. So if you got a really big zit and you got a really big date or prom or a Zoom meeting coming up, come on into the office. We inject it with a little bit of cortisone. Makes it go away a lot quicker, and more importantly, it will also lessen the chance of a scar. Chemical peels are great, in particular for whitehead, blackhead acne. And a little secret, if you have United Insurance, it's covered. Photodynamic therapy is a laser-like device where they put a liquid on the skin, let it sit for an hour or so, shine the light on it, creates an inflammatory response, free oxygen radicals, will damage your oil gland, kill the bacteria, and a few sessions of that could last very often for several months. Unfortunately, not covered by insurance. And of course, lasers for acne and acne scarring. You can see my wonderful board-certified fellowship-trained colleagues at Laser and Skin. So some before and afters for you from some of my colleagues, whether they're superficial or red or deep or just a really deep scar. Laser actually lifted that up and can sometimes even help some of the whiteness from scarring and some of the depth as well. Okay. So let's move on to rosacea. There's some similarities and differences. So we have basically 4 different types of rosacea, another inflammatory process, many of them overlapping. So we have your little butterfly lupus-like rash, redness and blood vessels, pimples and pus bumps, can look very much like acne, thickening of the skin, and little rhinophyma, but very important to keep in mind, it can affect the eyes. So whether it's dry eyes, in the eyes that people go see eye doctors for, or whether you're getting lots of styes, you got lots of styes, light skin, maybe it's ocular rosacea. So what's the cause of rosacea? Well, there's certainly a large genetic component, most common in Northern European light skin, blue eyes, although it does affect any skin type. Ultraviolet light, which might help acne, hate to tell you that, but it makes rosacea worse, so sunscreens every day. Stress, certainly a major factor, and this is a survey of 1,000 rosacea patients. And then weather, whether it's hot or cold or wind, and then really things that will make you red, things that will dilate your blood vessels and be more noticeable, whether it's exercise or alcohol or hot baths, spicy foods, anything that will vasodilate your blood vessels will make you redder and make it more noticeable. And certainly cosmetics or irritants, topical medications. Some people are very sensitive, some not. So again, we have more the redness and blood vessels and flushing. And sometimes that's what it takes to distinguish the flushing, to distinguish the history of that. We have more of the acne-like pimples or pus bumps, especially around the mouth, the thickening of the skin, and the involvement of the eyes. So a mild case in this light-skinned lady around the mouth could be acne, but as you see a little here accentuated in this lady, the background redness besides the blemishes, and an interesting phenomena where it's a little white sparing here, we call it, and that's a sign of rosacea, worsening with a little butterfly lupus-like rash, overlapping the pimples and the pus bumps, And again, if you have the redness to this degree, topicals will help, but laser will be needed. And then you have, again, your light-skinned blue eyes, and you could see not just the pimples and pus bumps, not even that scarring, but a thickening of the skin. This skin is hard. It's thickened, it's hard. And then we get the rhinophyma. So whether you're a sinner or a saint, if you're under 50, this is WC Fields. And thickening of the skin, potentially worsened by alcohol like him, but not this guy. Okay, and all skin types, again, maybe a little harder to appreciate the redness, but all skin types can get the pimples and the pus bumps and the papules and the rhinophyma and the scarring. Rosacea, get a rosacea-like presentation from topical steroids, which we always like to keep off the face, so what we might call perioral dermatitis, which means rash around the mouth, and it's just a localized form of rosacea, can happen around the eye. Actually, fortunately, a good type of rosacea has a good prognosis of going away quicker. Both, I should say, acne and rosacea have very variable courses. They can go on for a while, but they're certainly not life sentences, and everybody is different. Again, other steroid side effects. This is why you don't put steroids on the face for too long. A thinning of the skin, so to the point where it's breaking. It's bleached the skin. Blood vessel formation. Blood vessels are more visible. They're enlarged. And the only thing that will get rid of that will be a laser. But you got to stop those steroids. I know you'll rebound and look redder, but you got to get off of them. So lots of treatments, again, overlapping, many of them overlapping with acne. One thing that we didn't cover for acne is cilantro. This came out about, I don't know, 2 years or so ago, 3 years. And it's actually, I was skeptical at first. It's a very good rosacea medicine, probably my favorite, very effective. And we know that in some rosacea patients, there's a little mite that lives down in the hair follicle, a little Demodex mite. And if that mite overgrows, you get rosacea or a rosacea-like picture. The ivermectin, which kills mites, lowers that. But besides that, the reason why it works, not just for those subset of patients, is that it actually stops a lot of the cytokines, the inflammation in rosacea. The cilantro will block about 6 of those, and that makes it very effective. Phoenaceae, we spoke about for acne, of course, works better for rosacea. Cilantro also not drying at all, which is really nice. Phoenaceae a little bit drying. Great combination for these two. And now we have the brand new minocycline, so that's added to our new rosacea armamentarium. Metronidazole has been around forever. It's more likely to be twice a day, and it works, but I think not quite as effective. Sulfa works a little bit better for the rosacea than it does for the acne, and I rarely ever use clindamycin benzoyl peroxide, but since Clinda, again, has anti-inflammatory properties, it's a number 5 on the list. So more treatments than we used to have, which is nice than just a few years ago. And also relatively in the last few years, we have medicines that take those big blood vessels and just shrink them down. So on a day-by-day basis, if you're red, we have 2 medications, Rofate and Ravasso. They're vasoconstrictors. In about a half hour, they'll suck the redness out of you. They sometimes work so well, it looks like you're in a morgue, so you have to wear makeup. Most people, the people who like it, love it. A couple people don't like it because it could be a little blotchy. There could be a little rebound. Could look too pale. Makeup can cover that. A lot of people like this, but if you have this, be careful. You don't want to put this on all over for sunburn. It will get absorbed and it will drop your blood pressure. Kids have mistaken this for their toothpaste and they ended up in the hospital. So it's a pretty strong medicine. But if you don't want to put a cream on every night, every morning to take the redness out, of course you'll do laser. One more thing to mention, if you're getting redness and you're very red from your rosacea, you don't want to put on that steroid. We have medicines that work like steroids that don't have those side effects to help you tone down that redness when you're having a bad day. We have our pills, and again, really 2 of the 4 pills for acne are the same tetracyclines. Of course, the low dose Oracea, 40 milligrams, much more effective than rosacea head-to-head. And for those severe cases with skin hardening or rhinophyma, just nothing else is working, the Accutane. So the only thing that's going to work for blood vessels, unfortunately, once they're there, is laser. Laser is also great for taking down the redness. And if you have the rhinophyma, you can just kind of sculpt that down with laser. Can really beautiful results there. Thank you, and that's it. Thanks so much for watching. Thank you, Risa, and be happy to take your questions.
Perfect. Thank you so much, Dr. Seidenberg. That was a lot of fantastic information, and I know people appreciate it because the questions have already been flooding in. So before I get to them, on the bottom of your screen is a Q&A. You're welcome right now to go and input any questions that you would like Dr. Seidenberg to answer. All right, let's get started. So a couple of these came in before you even started, so hopefully they are still relevant. Is it common for rosacea to make the skin feel sensitive?
Yes, so it's interesting because there are some patients with rosacea who are very oily and not sensitive, and we want to dry them out, so we'll give them Finacea. And then there are, but very common to be just very sensitive. You know, sunscreen aggravates you, the makeup, the sun aggravates you more, topical products, so that is a fairly common, usually more so with the lighter skin types, and you might even be flaky. And you'll probably be dry. So rosacea, you could be oily or dry, but yeah, that's a third of the people dry, normal, and oily. Yeah.
Got it.
If
Okay.
if you're dry, we'd go more towards the Sulantra and hold off on the Finacea.
Okay, this one's from Corey. If you have acne, should you use a vitamin C serum?
Good question, Corey. I think that's vitamin C is more for anti-aging. Not that there's no effect, but there are so many well-proven, better studied medicines for acne prescriptions that I think you're kind of shooting a little bit low on the totem pole. Also, if you never know what's in your vitamin C. It's a very large molecule. The absorption is questionable. It's like when you go into GNC and studies have shown what's on the label may not really be in the bottle. And it's also could be irritating. And, I'd much rather have you deal with some irritation of a retinoid, which nothing has been more studied than retinoids. If you do nothing else from this lecture, the two things is a sunscreen every morning, retinoid every night, you'll have better skin in 10, 20, 30 years. So yeah, maybe there's some help, but not the way I would go. Good question.
Got it. Great. Okay, let's see. This is from Wayne. Sunscreen makes my rosacea worse, even oil-free sunscreen. What's the best sunscreen to use? And also, what's the best face cleanser for those of us with rosacea?
Okay, so great question and a common question. And, before we talked about myths and realities and the oil-free concept or alcohol-free concept, there's really lots of types of oils, there's lots of types of alcohols. So I don't get too hung up on alcohol-free and oil-free. A lot of things that have alcohol are not drying at all and vice versa. So, but if you're looking at a sunscreen, then you might try, with a sunscreen, it's not about the brand, it's about the active ingredient. So oxybenzone, which I try to avoid anyway, because it's the #1 sunscreen to be allergic to. You have to worry about if it has some hormonal effects. And so I try to use zinc and titanium when I can. And of course, they're not just the white ones of the Lifeguard, they're chopped up. You get a 30 or 50, they go on clear. And I think those physical or mineral sunscreens are usually less drying, less irritating, but of course there's always going to be a little bit trial and error. And again with moisturizers, there's going to be trial and error. Things don't have to be expensive. Cetaphil, Neutrogena, CeraVe, Eucerin, petroleum jelly is still non-comedogenic. It's hard to believe, but we talk about oil, you think it clogs your pores. You can put Vaseline petroleum jelly on your face. It doesn't cause acne. We put it on all the wounds that we create in the office. So another very good question.
Okay, great. If everyone's okay, I'm going to remove the screen of Dr. Seidenberg's contact information so you can see him a little bit better while he's talking. So if you want to take, oh, so if you want to know how to contact us and you missed anything, you can take a screenshot right now, or you can also use the chat feature. All right. So now he's a little bigger here. All right, so this is a related question. So Wayne says, or sorry, that was from Wayne. This is another one, anonymous. My wife would like to know a recommendation about skincare for people with rosacea. Serums, moisturizers, basically what's best to use and what should we avoid?
Okay, I'm sure this is for your wife. Okay, so as I kind of alluded to in the last question or two, I'm a little bit of a therapeutic nihilist, a little bit of a pessimist of what's out there. You know, again, if you go into GNC with 1 million supplements, there's about 3 supplements that have ever really been proven to work. So vitamin C could be irritating, as we spoke about. Sunscreen is important for 1 million different reasons, because ultraviolet light makes your rosacea worse. Even ultraviolet A is in the wintertime, it comes right through the glass. It's in your office, it's in your car. Even some indoor fluorescent lights can worsen your rosacea or your skin, sun damage and skin cancer. So every single morning, it's not a question of if I put on a sunscreen, it's which one am I putting on. I just kind of make believe it's my aftershave. So a day like today, it's a nice day. I'm inside all day. It's a moisturizer with zinc and titanium about a 30. If I'm out on a hot summer day, it's a zinc titanium if possible a 50. If you're still getting color through that, which many people will, or you're playing tennis for 3 hours, then I might bump up and use an oxybenzone, maybe not my whole body, on my face or neck. Go to like a Neutrogena Ultra Sheer 85, still goes on pretty clear. But you know, if you're alone in the pool, if you're throwing your kids in the water, take the good old-fashioned lifeguard sticks. They come in lots of different colors now. And if you can see the light, the sun's not getting through, and I highly recommend it. Moisturizers I kind of touched on. It's going to be a little bit trial and error. Same thing with makeup. Let's face it, most makeups by very large companies are non-comedogenic. They've been tested, but there's always going to be person-to-person variation. If there wasn't, I wouldn't have a job.
Great. All right. This is related as well from Bernice. Should I use a sunscreen while indoors?
Yeah, so kind of like as we touched on, I do every morning. It's a little bit, you know, if you live in, if you work in the basement, you know, so if you're one of those basement Zoomers, you never come out of the basement, then no, you don't need a sunscreen. But if you've got a sunny window, if you've got a nice south-facing window, look at the couch, look at the carpet, they are faded. And that is ultraviolet A light going right through the glass. Pilots get more melanoma. Truck drivers get more skin cancer on the left. In the old days when men were the drivers, women the passengers, men get more skin cancer on the left, women more on the right. This is all proven. Ultraviolet light goes right through the glass. And importantly, nice big glasses. Multiple reasons. You're squinting less, so you have less wrinkles. You're protecting your eyes from cataracts or glaucoma. You're protecting your skin from freckles and sun damage. And you want to make sure those lenses are 99 UVA and UVB. Do not buy cheap sunglasses that will tell you it's 99% UVB, because UVB doesn't go through glass. It's got to say 99 UVA and UVB. Nice big Jackie O sunglasses have 4 wonderful benefits for you and your eyes and your skin.
All right, I think we all need to go back and check our sunglasses now. Okay, here's an anonymous one. You mentioned exfoliators were not effective. What about chemical exfoliators like AHA and BHA?
Is this the same anonymous or a different anonymous? Okay, so there is some benefit to exfoliating, and you know, this is a big debate. You can go back and forth about how much you need. It also really depends on what your regimen is. So I'm not like totally against exfoliating, but you know, I don't want you scrubbing away, especially if you're medium or darker skin type. If you scrub long term, you're going to start causing pigmentation and get 2 different skin tones. Also, if you're on a retinoid, which is really the best thing for your skin, for so many reasons, the retinoid is sort of an auto exfoliator anyway. It's going to thicken the skin, thicken the dermis, but it's going to make your epidermis more compact, more smooth, more even. And so if you're doing that, you don't want to exfoliate, which now you might be more dried out. You may not tolerate your retinoid as well. So it's okay to use an AHA or BHA. And when we talk about the chemical peels, in the office I use a Jester's peel, which is salicylic acid, lactic acid, or sorcinol. Because not only is it keratolytic, which means it just peels the whole skin, it actually focuses on the whitehead and blackhead. It's comedonolytic, so it goes right down. You look at the skin, you see all those little white dots where the whiteheads and blackheads are. So it's a great peel for acne, not to mention a very safe peel for acne for all skin types. And so directs right towards the follicle. So I'm not completely against exfoliating. I just wouldn't overdo it, or I'd let the retinoid do it for you. But great question.
Okay, here's another one. Good one from Corey. Do LED lights really work, and should I use one at home?
Okay, that's a great question. So yes, they do, but it really depends what you're talking about. So these machines in the office are, thousands of dollars. Now I know you can go online. I know when I see my Indiegogo account, I can get a LED lights for whether I want to grow hair or help acne, and it's $40. But believe me, this is not the same thing. It's comparing a flashlight to a laser. The technology involved cannot be delivered to your door for $40 for the most part. So yes, they're helpful. So there's the blue light, which has a little bit of effect, and the photodynamic therapy, which we talked about, where you put the chemical on the skin, let it sit, shine a red or blue light on it. And you'll see if you ever got PDT, you get a really brisk inflammatory response, like get a deep chemical peel. You gotta be home for a week or so, and that can definitely chill out acne. A few visits, a few sessions, chill it out for a few months for people who can't take the pills or Accutane for whatever reason. Just a little blue light alone, it's a mild effect. Great question.
All right. I'm actually interested in the answer for this one. This is from Mary. What is the effect on acne if the vellus, I hope I said that right, hair on the face is removed?
No significant effect. And even if the terminal or darker hairs are treated, and of course, the answer might really lie not so much in the hair, Mary, but how you're removing the hair. Because if you're taking out if you're waxing, you can get an occlusion type of acne or mechanical acne. And now eventually the hair grows back and it can get an ingrown hair, which may look like acne, but it's not acne, but looks very similar. So it might be more about the procedure than how you're using it, about the hair itself.
Okay, when I read that, I thought maybe they meant dermablading.
Okay. Dermablading, if they're not, for the most part, not a problem. I mean, theoretically, a little ingrown hair, but not a major effect on acne. Yeah, I'm okay with that. If you're not
Okay. All right, here's a good question from Marissa. What are the long-term effects of Accutane?
Great question. So for acne, hopefully you'll never see me again until you need some skin checks. I know it's a real practice killer. But for the most part, none. So, it shrinks up the oil glands and you get this long-term cure, but the dryness goes away. But another long-term benefit is less scarring. Again, not every case is a cure. You can get pregnant a month after. Again, whether you're asking about mood effects, this has not been proven. Of course, there could always be a case here or there, but in large studies, there's no mood or long-term mood or colitis. These are things that have not been shown. If there's another particular side effect you had in mind, let me know. But for the most part, yeah, it's, like I say, it's out of your system and you get pregnant a month later. And you can go get your laser, depending on what type of laser, right away or maybe 6 months later. And this is a medicine that's, I know there's a lot of controversy about it. It was very, especially, 10 years ago, a lot more worry. But we've got more of a handle. We got great studies we didn't have 10 years ago. It's been out 30 years. And so we got generation and generation of Accutane out there. People worried about bone. So let me just comment on the bone. There could be an eye. There could be very structural changes seen on X-ray. They are not functional in any way. What happened was there were some kids who had born with severe skin disorders on mega dosages of Accutane for decades. They had a couple bone closure early, but we're not giving it to kids at that age. So there is no premature closure. They're not short stature, though that's not an issue that people were worried about 10, 15 years ago, perhaps. Yeah.
Got it. Okay, this one's from Arlene. We have a couple more left, if that's okay. Arlene says, what medications work best for ocular rosacea?
Yeah, so if you go, I don't do the eye drops, but there are definitely topical medications, eye drops for ocular rosacea. But what I think is somewhat underappreciated is are the doxycycline. So the 40 milligram doxycycline is very effective for ocular rosacea as well. Most eye doctors know about it, or for some reason they seem to send the patient back to me for that, or they'll just use the drops. So there are some cortisone drops, cortisone antibiotic drops. They might use dryness drops for dryness, but the doxycycline, if your dry eyes are just from diagnosis rosacea, the low dose doxycycline is quite effective as well.
Okay, here's another question, another anonymous one. If you use azelaic acid for a long period of time, does it stop working? And maybe I could add on to that, probably the same question for any of these, if you use benzoyl peroxide for a long time.
Right, so the azelaic acid, no, to the best of my knowledge, you don't get immune to it. Another question people might ask, will it bleach your skin? The bleaching effects are relatively, quite subtle. So we don't see that too often. The benzoyl peroxide, again, is not a true antibiotic in the common classic sense. You don't get immune to it. But and erythromycin, you're probably already immune. Clindamycin, you can get immune to, so we combine those with the benzoyl peroxide. You don't get immune to retinoids. The cilantro is so new, but again, there are antibiotic effects, and there are in rosacea more so anti-inflammatory effects, and you don't get immune to the anti-inflammatory effects. And you don't get immune to the Rosacea because it's the 40 low-dose doxycycline, because again, it's not an antibiotic.
Okay, here's another question from Marissa. I've been getting into a more consistent routine of washing my face morning and night, but I've noticed more frequent breakouts with lots of little blackheads and whiteheads. Am I overwashing? Is there still a way to remove dirt and pollution from my skin without irritating it too much?
Okay, so I'm not so. It's first of all, it's unclear, why that's happening. I mean, if you're doing it very brisk, theoretically you could exfoliate and close the pores almost as much as you can open it. So if that's the only thing that changed, then I would probably go back again. I don't know what type of work you're doing during the day, but I mean, I would use a mild soap. If you're not very dirty, you may not have to wash as often, or use something milder. If you're not exfoliating, maybe exfoliating works for you. If you are, maybe you should try not. Of course, there's some medications you can start. If you're doing nothing, you can try as over-the-counter salicylic acid wash to open up some whiteheads and blackheads. That's might depend on some of the products you're using. That's one I'm not quite sure about. There could be a lot of different reasons, and maybe a little bit of trial and error.
Okay, great. All right. If anyone else has any questions, we just have one left that I'm going to get to right now. Anyone else? This is the time to type them in. So let's see. This last one, can diet really affect acne?
That's a question for the ages, and we'll be debating that when I'm in a nursing home. But I think, we had studies with diet years ago, and then we kind of had to throw out some of those studies because our whole concept of what we know about nutrition has changed. And doctors, we're not the most, we don't learn a whole lot about nutrition. Hopefully they're learning more, but everything we understood is just flipped and flipped and flipped. So, again, the French paradox, so why can they eat so much cheese and stay thin, or why they have less heart disease than we do when they eat what we think is such a bad diet? Why does a Snickers bar have a lower glycemic index than whole wheat bread? So we just don't know so much about diet, and we learn every 10 years something new. And so what the studies were going to do. But you know, for 2020, I really, and believe me, I'm a nihilist. I really never thought milk was going to be a problem. Someone once explained to me, I forgot the reason why low-fat milk in particular might be worse than whole milk. Again, I just avoid dairy personally, but we are finding, whether it's, you know, for psoriasis or other autoimmune conditions, inflammatory conditions in the body, that the Western diet, which is, you know, the wheat that you eat now is so much different from the wheat that you ate 50 years ago. It's got 3 times as many chromosomes. It's, you know, if you look at the amber waves of grain to what wheat looks like now, it's completely different. It's how it's affecting us is not well studied. Then we have big ag and coming into this with their profit motives and antibiotics in our foods and our, you know, and wet markets with antibiotics and coronaviruses. So eat healthier. It doesn't have to be vegan or vegetarian, but Mediterranean. I think there's so many other reasons to eat well that, you know, I can't, you know, I've had people tell me they've changed their diet, their acne has not gotten better. But of course, I don't see the people who change their diet and their acne goes away. So I'm sure it's helping some people, but not everybody. Everybody is different. And we all know, we've seen 2 people eat the same food and one gets fat or gets acne and one doesn't. So everybody is different as well as every diet.
Okay, beautiful. All right, well, thank you so much, Dr. Seidenberg, for your time. Thank you to everyone who tuned in. I want to remind you that Dr. Seidenberg is available for consultations and appointments right now in our New York City office. You can go to our website to make an appointment or call us. And I also want to remind you all that next week on Wednesday, we have another webinar from Dr. Brown, and he's going to be speaking about tummy tucks and mommy makeovers. So a very different topic. But I hope overall that this was very educational and helpful for you. When you close down this Zoom, you will get a survey. We'd love your feedback. The recording from this will be available and sent out this weekend. So I know Dr. Seidenberg went over a lot of information that will help you if you want to pause and go back and look at some more of his slides. And it's also available already on Facebook because we are streaming live there. So you can go look there. But otherwise, thank you so much, Dr. Seidenberg.
Thanks so much, Risha. And thanks so much, guys, for taking the time to watch.
Okay, bye, everyone.
Bye-bye.